I am Michele Cannone. I'm from Italy. I'm a physiotherapist and a project manager. I'm at the moment a proud chair of the Cancer Working Group of the Europe region, World Physiotherapy. What are working groups? Working groups are the heart beating of the region, because through working groups we are able to publish research, do projects, impact in Europe, and have good networking with the major stakeholders around the world of physiotherapy in Europe. Cancer Working Group in particular had done some very impactful project. First of all, a couple of years ago, we published a position paper on the role of physiotherapy in cancer care. You can find it online in our website. We are running a project about entry-level competencies for physiotherapy in cancer, because after a survey, our analysis came up with a lack of entry-level competencies in IL entry-level institution. And we also do a lot of dissemination through webinars like tonight, podcast, congresses, and we will be also present to the next Congress of the Europe region, but we will speak in a few minutes about it. And also, we have a good relationship at Brussels with EU institution. We were able to publish the impact of physiotherapy in cancer also with the Europe Cancer Organization inside the Beating Cancer Plan. What about tonight? Tonight is about clinical cases. Why clinical cases? Because you requested it. After a lot of webinars on theory, you people requested it to go from theory to practice. So tonight will be all about practices, and I hope you will appreciate it. And we will have three wonderful speakers that Marianne will introduce later on. I will stop here just with a reminder to be part of our European congresses in the beautiful city of Madrid, the next 5 and 6 of November. It won't be just an education congress. There will be plenty of topic for everyone. And also our cancer working group will be there with a networking session that is a chance to know each other, to get in touch with each other, and to speak about physiotherapy in cancer. And also we will have a focus symposia on, let's say cancer physiotherapy for dummies, but it's approaching to all the physios to be prepared to deal with cancer patients, even if you are not working specifically for the cancer disease. So if you are a musculoskeletal physiotherapist, but you get in touch with the cancer patients, you have to know something. So be there, please. Take note, open your calendar, take note, and try to be there. Now I hand over the floor to Elena. She's a member of the IPT-HOPE, to introduce herself and to speak about the IPT-HOPE.
Good evening, everyone. My name is Helena Stillman-Cohen, and I'm the education lead of IPT-HOPE. IPT-HOPE stands for International Physiotherapist for HIV/AIDS, Oncology, and Palliative and Hospice Care. So we are a global group within World Physiotherapy, bringing together clinicians, researchers, and educators working in these areas. So we have member and liaisons from over 20 countries around the globe. So it's very international and collaborative community. Our main focus is sharing knowledge, supporting education, and helping advance best practice in physiotherapy. We're really happy to be collaborating with the European region group on this webinar, and we truly appreciate this opportunity to work together. We also provide webinars, so we are happy if you will join us as well. And thank you so much for joining us today, and I hope you enjoy the webinar. Thank you.
Good evening, dear colleagues and participants. On behalf of the Europe Region Cancer Working Group, I have a great pleasure to welcome you to the webinar that is titled Empowering Recovery, the Role of Physiotherapy in Cancer Care. In this evening, we will hear expert lectures from our colleagues. And our first speaker is a dear colleague from our Cancer Working Group, Nirit Rotem. Nirit is the head of physiotherapy department at Tel Aviv Sourasky University Medical Center. She's also a researcher, educator, and a clinician. Her presentation from wheelchair to deadlift rehab of a young patient following CAR-T treatment will describe the road to recovery of a young patient following CAR-T, the groundbreaking personalized immunotherapy. Nirit, go ahead, stage is yours.
I will be presenting a case study which was conducted by our lead oncology physiotherapist, Ilan Tausig, at our institution a few years ago. And I will, a very young, relatively young patient having a CAR-T treatment. Just to say, all pictures and details are with permission of Dana, the patient, including the name. So Dana was age diagnosis was 26. She's currently 30. Time has passed a bit. She's a graphic designer, highly active. Lifestyle factors are she went to the gym regularly, swimming. She was just finishing a entry-level degree, and she had a diagnosis of lymphoma. And like many cancer patients, her life started moving in parallel trajectories, clinical reality and the personal resilience or personal the life that went on. So on May 2019, she was diagnosed with lymphoma. On October 11th, she had her wedding. They would not postpone it. She was already in treatment, and they would not postpone the wedding. Her hemoglobin was critically low just before the wedding, but after the transfusion, it rose to 8.3, which is just fine. And they were ready for her to be very weak and put chairs everywhere around, but she managed to put the illness aside, and as she says it, she danced the entire night. And then later, her honeymoon was spent at Rambam Hospital. She lived in Haifa then to receive her sixth treatment. But this is a picture from her wedding. You can see that she was already going through treatments, but she wouldn't postpone it. It was important for her to go ahead with it. And then there was a disease relapse at 2020 in March, and then she had a CAR-T transplant at Ichilov, following bridging therapies with immunotherapy medications. And in March of 2021, she concluded all her medical treatments and got to rehab, outpatient rehab. So there is as we see, CAR-T is not a first-line treatment usually. At the time she was at 26, she was the youngest that received this treatment in Israel. The hospital, Ichilov Hospital, Sourasky Hospital, is one of the primary researchers of CAR-T. Worked in Ichilov, so it is a pioneering hospital in that technology, and it is still not a first-line treatment, but it is being used more and more. So her initial symptoms, Dana's initial, were dry cough, choking sensation, and then they discovered a cervical lymphadenopathy at the upper sternumus. She went through a first-line therapy, and then a relapse and refractory disease, and she went some more chemotherapy, and which she didn't respond to well, and then it was decided that she will undergo CAR-T treatment, and then there was the bridging therapy and the final intervention, which was CAR-T. Now, CAR-T, the intervention is basically re-engineering of the immune system. There is a process of extraction of patient's T cells. They are harvested and isolated. There is genetic engineering. Cells are lab modified to express receptor targeting specific cancer. proteins. There is then a multiplication and reinfusion of those engineered T cells that are injected back to the patient. And then those, hopefully, what the new T cells actually attack the cancer cells and destroys the cancer. It is a highly effective one-time intervention, but one that exacts a severe systemic toll, and you will see it in a minute. It is now CAR-T is being tested in other diseases. I've just saw the other day a study done on lupus patients with excellent results. I think I understand there are some good studies on MS, so it is a very promising treatment, but it is a treatment which is the harsh systemic toll is very visible and is very prominent. So with Dana, when she came in, her Z-score was minus 2.1, which is significantly lower than expected at 26 years old. So she was considered having osteoporosis, and is both the treatment and the steroids, which are which are given during the different treatments. So she was at her 26 years, she was osteoporotic. This is her when at this time. Mobility-wise, she was confined to a wheelchair for about 6 months post-relapse. Because of the different treatments she was going under, she was wheelchair confined. Her stamina, she was barely able to stand or walk the short distance from the living room to the bathroom, indoor, very in-house, very difficult for her. And she was totally reliant on her husband for basic ADLs, including washing and dressing. She needed help in everything. She was very, very weak. So her ideal status was showering. She was required her sitting or constant supervision, dressing, intermittent sitting, and some help. House chores, which were important for her, were extremely difficult, even the most basic tasks. Indoor walking required supervision, and it was for very short distances. Outdoor walking liked physical assistance. She has a very supportive husband and family, and she was a high fall risk, which was alongside her osteoporosis, was also always a danger we needed to factor in. Her baseline clinical metrics were the 30-second sit to stand was 14 repetition, which is not high, and her hand grip strength was about 20. Those are the two basic clinical metrics we use with all our patients. There is very good support for it, and valid and reliable and responsive, which is also important. So defining the rehab goals, first goal was mobility endurance. She wished she could walk continuously outside for 30 minutes without needing to stop or rest. Descend stairs reciprocally without relying on handrail or physical support. A more complex ADLs, house chores again were important for her. And the ultimate goal was to return to regular pre-illness physical activity and exercise levels, which, as I mentioned, were quite high. Her activity had 3 pillars. One was a community support group. Hala Sartan is a patient group for younger patients. She joined them at weekly sessions at the Yarkon Park, which they conduct quite a lot of groups. There is a very popular rowing activity there, and psychologically it contributes a lot. She worked at the pool. We have a pool in our facility once weekly, and it says focus on balance and low impact strengths. The physiotherapist is a triathlete. He is doing a very, very, very hard sessions, aerobic as well, which they really like. They really, really make an effort to get to the pool because it is very hard, but still more comfortable maybe than outside. And physiotherapy, individual weekly sessions with Ilan, targeting strength training and guidance of the whole rehab. And that's her, and she that's the deadlift from the title of the lecture. She's as a personally she likes to go to the more extreme for her relatively extreme weights. So there are very few repetitions. She's going all out. So with deadlift, she reached 42 kilos, which were for her was a nice achievement and a goal she was happy with. And shoulder press, just over 10 kilos, 2 reps. Again, her preferences was the low repetition numbers and a higher weight. And this is in the background, you can see our physiotherapy department and the weights are there. And we need them to work with the patients. At the same time, there was in the background or in the foreground, I don't know, holistic medical management. She had an immune reset, so she completed her full childhood vaccination schedule because of the manipulation of the immune system. She needs vital monitoring, PET-CT, regular PET-CT, and EKG, lung function tests, and whatever, and bone health, which was aggressive tracking of bone density using DEXA for osteoporosis. Her update, the scan results, she went from minus 2.1, which is osteoporotic, to minus 1, which is perfectly normal for age. So that problem was over by 9 months. You can see that. Her clinical metrics were from 14 reps to 27 reps. In the sit to stand, 30-second sit to stand. Hand grip was improved. Her left hand grip wasn't improved that much. She didn't have much of a. There was no other problem. It was just she is a right-handed person with weaker left hand. Her symptom resolution neuropathy and severe pain were significantly reduced or entirely resolved. All functional goals were achieved. Functional independence restored. She could do whatever she wanted at home, and again, that was important for her. She cooking and cleaning and whatever without fatigue or need for assistance. Her community engagement grew. She doubled her weekly participation in the Sartan physical activity group. Her mobility was reclaimed. She was she traveled to Greece. She was very proud of climbing the Wolf's Hill in Athens. She sent quite a few pictures from there, and her systemic health was back to normal. She is actively managing nutrition and steadily returning to a pre-illness baseline weight. She came, that is at the Tel Aviv Night Run. What her shirt says is, I have cancer, but I'm ahead, writing on her shirt. I have cancer, but I'm ahead of you. You can see a body change. It wasn't the full marathon, but she ran quite 5 kilometers without a real problem. And best for last, just last year, she and that's her now. And I mean, she's very much changed from the time of treatments. And she had a baby. And there was that's on the right. That's why Israel's probably #1 news outlet, and they published it, and she was a very proud mom. So that's the case. I understand the question and answers will be at the end, and thank you for listening. And I'll be here later for the questions and for the Q&A.
Our next speaker is Marta Charalampopoulou. Marta is a physiotherapist and PhD candidate at the Medical School of the National Kapodistrian University of Athens, with significant clinical and research activity in the field of oncology, rehabilitation, and therapeutic exercise for people with cancer. In her presentation titled Therapeutic Exercise in Oncology Patients, Evidence, Safety, and Prescription, she will share with us the latest scientific evidence on the role of exercise in cancer care, as well as practical guidance for its safe and effective prescription in clinical practice. Maria, thank you very much for being us today. We look forward to your presentation.
Even though this webinar is quite more practical, I would like to start with a little bit of the scientific part, and then at the end I will show you a clinical case from my praxis. So my lecture will briefly show the evidence supporting the therapeutic exercise in oncology, safety considerations for physiotherapy praxis, practical exercise prescription in cancer patients, and strategies to support patient behavior and adherence. I would like to start this presentation with breaking news. This is a clinical practice guideline, as you can see from the title, that it was published in an express mode since 3 months ago. Actually, it was in January 2026. And this is a very interesting thing, because it's the first time that the ESMO, which is a very important organization, society actually, highlights the role of physical exercise in patients with cancer. This is very important to note, that this organization, this society is highlighting this thing, because exercise improves clinical outcomes, including survival. They also say that exercise increases disease-free survival, also improves overall survival, as well as improving physical function. This is something that now shows that exercise is a part of evidence-based oncology care. This means that oncologists should know, and this is confirmed by this, by the society, that finally exercise is no longer optional. It is part of their weapons. So now it is not just a suggestion, it is part of their adjuvant treatment. This guideline came from a study, which was one of the biggest studies, which lasted for 3 years. It included patients diagnosed with colon cancer who had had surgery and had completed their adjuvant chemotherapy. These patients were in stage 2 and 3 cancer. So the sample was more than 900 patients. And it was international randomized clinical trial. The sample was collected from 55 centers. And there were 2 groups. The one group received structured exercise, and the other one was just recommendations for physical exercise, physical activity actually. And this structured program included more than 150 minutes of aerobic training weekly, as well as behavioral support. from this study, it was proposed the biological mechanism which showed that the exercise acts on multiple biological pathways that are relevant to tumor progression. Exercise reduces insulin and IGF-1 signalizing, lowers chronic inflammation, and enhances immune surveillance, particularly the natural killer cells activity. And in parallel, it improves metabolic regulation and the tumor microenvironment. And together, these effects may reduce tumor growth and recurrence risk, as demonstrated in this study. So we have a study which is not just observational. In this concept, we see that exercise is considered part of it's a medicine. So based on this evidence, exercise is no longer just supportive care, as I already mentioned. It is a prescribed, individualized intervention in oncology care. But as every medication, it needs dose, it needs timing, and it needs personalization. But it doesn't come in a pill. So our job is to deal with several problems, because here we have the clinical challenge, because in clinical practice, things are not so simple. Patients are highly heterogeneous. Treatments have multiple side effects, and functional capacity can change rapidly. In addition, behavioral barriers such as fatigue, fear of fall, and other fears, as well as low motivation, often limit participation in such programs. So the challenge is not whether exercise works, but how to implement it in clinical practice. So beyond the evidence, we already know that from several studies that exercise reduces fatigue, improves physical function, enhances quality of life. And now we have the guidelines for recommended exercise. We had it, but now it's just with the stamp of the ESMO. But the important clinical question is, how do we prescribe exercise during treatment? How do we adapt to fatigue, neuropathy, and metastases? And how we can support patients to remain active over time, as well as to be motivated. These are all issues that are faced by us. So as mentioned before, this is not whether exercise works, we know that, but how we can implement it in the clinical practice. Before planning on organizing a program, an exercise program, we always have to think about the safety, which is the first step for prescribing exercise. For example, we have to consider the medical status of the patient. In case of anemia or cardiotoxicity or infection, or maybe we should, not maybe, also we should consider the cancer-related complications, maybe bone metastasis, which increases fracture risk, or the peripheral neuropathy, which increases fall risk. In treatment-related side effects, fatigue or deconditioning is also a matter that we have to deal. Also, lymphedema is something that we should consider, or we should adjust our exercise. And also functional capacity and strength. So the goal is not to avoid exercise, but to adapt our program of the patient in a safe mode. Exercise prescription should be individualized according to the patient's condition and the treatment phase. In general, we aim for a combination of aerobic and resistance exercise. This is a table which is adapted from Campbell, Dr. Campbell, and the guidelines are from the American College of Sports Medicine, which show, if you go through this paper, you will see that there are for different type of cancer, what is prescribed for each kind of type stage as well. So I took one part, so I could show you the principles of prescription. So it would should follow with the frequency, with the intensity, the time, and the type. So about the frequency, 3 to 5 days per week aerobic activity. The intensity, it is moderate intensity, and it should adapt to symptoms. The time is recommended to be 20 to 40 minutes per session, and the type is recommended to be aerobic and resistant training, and in the resistant training, 2 to 3 sessions per week, focusing on major muscle groups for 1 to 3 sets of 8 to 12 repetitions. But in general, actually not in general, the key principle is simple. We start low, we progress gradually, and we adapt continuously. And it's not exactly a fixed program. It is a flexible and patient-centered approach. Exercise should be adapted to treatment-related effects. For example, in fatigue, we reduce intensity and duration. In case of chemotherapy-induced neuropathy, we focus on balance and safety. In case of bone metastases, we avoid high-impact loading. And in severe deconditioning, we start low. So the exercise becomes symptom-guided and individualized. But what we also have to face as physiotherapists is also the behavioral barrier of the patients. So even the best program that we could organize and we plan it perfectly, patient might not adhere. We might hear patients say that I'm too tired to exercise, I'm afraid I might fall, or even what is the point of this exercise program? Or even if the person is motivated to follow an exercise program, he or she doesn't know what to do. So our role is to translate these barriers into practical strategies. We start with small, achievable activities, provide reassurance about safety, and we encourage activities that are meaningful to the patient. Adherence requires flexible and symptom-adapted exercise. Something which is interesting for a person is it is more possible that the person would follow it. So in order to illustrate how these principles apply in practice, I will present a clinical case that one of the patients that I have. This is a 59-year-old woman. She was diagnosed with kidney cancer, and she had very soon bone metastasis. She had a femoral recession after a pathological fracture. Actually, she started with a nephrectomy unilateral. Then she had the radiation therapy in the metastatic areas. Then the femoral recession came after the pathological fracture. This caused a limb-leg discrepancy of 5 centimeters. It also restricted her range of motion in the same leg. She also has hypoesthesia due to the radiation in the ilium. And she's in hemodialysis for 3 times per week. She has fatigue the days of the hemodialysis, and she had also reduced function. She's also taking chemotherapy, so in a pill. So she has many gastrointestinal side effects, and this also causes low mood. And also because of this disbalance, all these disbalances, she had fear of moving. So in this context, exercise needed to be carefully adapted. We focused on functional mobility, such as sit-to-stand and supervised walking, combined with low-impact strengthening and balance training. The aim was not performance, but meaningful and manageable daily movement. So, despite the complexity, she has improved her confidence with mobility, and she's able to maintain daily activity. So the exercise was adapted to a highly complex clinical context. And I have to mention that this patient, I met her, the first time I met her was for her secondary lymphedema of the lower leg, the same that she had the fracture. The fracture was, actually the lymphedema was before, many years before the fracture. So I treated her lymphedema and everything was fine. And she moved to the United States. And then after 2 years, she came back to Greece. And I saw this condition that I described you. So we have very a lot of contact, and I follow her a few days in the week. So we'll conclude that, and I would like to from you to keep in mind 3 key messages: that exercise is beneficial and recommended in oncology care. Therapeutic exercise can improve fatigue, physical function, and quality of life. Exercise prescription must be individualized. Even though we have these guidelines, we always have to think that we have one patient who is completely different, so one size doesn't fit all. Physiotherapy should consider treatment effects, comorbidities, and functional capacity. And last but not least, supporting behavior is essential for long-term adherence. And small achievable goals and encouragement help patients maintain long-term physical activity. And thank you for listening.
Next, we have the final presentation of the evening, and it's from Marta Skudra. Marta is a physiotherapist specializing in urology and and gynecology in oncology. During her master's studies, she researched rehabilitation after prostate cancer surgery, focusing on physiotherapy's role in reducing urinary incontinence, restoring sexual function, and improving quality of life. She currently works at Riga East University Hospital, Latvian Oncology Center, where she supports patients after radical prostatectomy. She also teaches physiotherapy in oncology at Riga Stradiņš University. Her title of the presentation is Postoperative Physiotherapy Following Prostate Cancer Surgery, a Clinical Case Report. So please welcome Marta.
For today, I want to introduce with my presentation and clinical case. In this presentation, I also include information on anatomy. I would like to point out that many of these images are designed as visual aids that I show to my patients also. This helps to educate them about the pelvic floor musculature and its functional significance, ensuring they fully understand that we will be training and how we will be doing this. I also use these materials during the preoperative consultation to educate patients about potential functional issues and the possible preoperation physiotherapy. In my opinion, this is crucial since we cannot see the action of this muscle and they are difficult to palpate. We must provide the patient with a clear visualization. And today I want to give you a huge information, and let me start it right now. And we start with the basics. What exactly is a prostate? The prostate is a small gland that is a part of male reproductive system. It is located just below the bladder, in front of the rectum, and it surrounds of urethra, the tube that carries urine out of the body. The main function of the prostate is produce fluid that nourishes and protects sperm. This fluid mixes with sperm cells and forms semen. Although the prostate is a relatively small organ, about the size of walnut, it plays a central role in male fertility and urinary function. Prostate cancer is often silent in its early stage. Most men do not notice any symptoms. As this disease progresses, however, patients may start to experience certain symptoms. The most common are urinary problems, such as frequent need to urinate, especially at night. Some men may notice blood in the urine or semen or difficulties with erectile function. In more advanced cases, pain can appear in the back, hip, or chest. There may also be numbness in legs or feet and even problems with bladder or bowel control. In men, prostate cancer is the most common type of cancers. Another important point is a trend we are currently seeing. Prostate cancer is no longer only a disease of older men. More and more cases are being diagnosed in younger men as well. This makes the topic especially relevant when we think about prevention, early diagnosis, and rehabilitation. This figure leads us to believe that we will need a large number of physiotherapists working in this area. Quite often when we think about the pelvic floor, the training course and materials out there are most frequently designed for the woman. That is a problem right today. And now I would like to share a clinical case. The patient underwent surgery in September 2025, and first I met him in October. Due to elevated PSA levels, the patient underwent diagnostic investigation, which confirmed prostate cancer in a localized stage. No distant metastases were detected. Radical treatment was indicated, and the patient consented to surgical management. The patient was informed about the expected outcomes, the treatment process, and the postoperative period. Planned surgery was radical prostatectomy with bilateral regional lymphadenectomy. The procedure was scheduled for early September. After surgery, the doctors did more tests. They found a few cancer cells very close to where the prostate used to be. Because of this, patients will need radiation therapy. However, he does not have to start it right now after surgery. The doctors will watch his health closely and wait for the best time to begin. On this slide, we can see the main step of radical prostatectomy that are particularly important for us physiotherapists. First, we notice the surgical incision. This immediately reminds us the scar will be present and we will need to assess and address it during rehabilitation. Next, part of the rectus abdominis muscle dissected. This makes us think about the potential impact on the abdominal wall and how this may affect overall core stability and function. A very important step is the removal of the prostate itself. During this procedure, ligaments is detached. As a result, the bladder will be positioned lower than before. In this image, we see the prostate being separated from the urethra. This has several implications. Nerves and muscles are affected, and the functional length of the urethra is reduced. All of these surgical aspects directly influence the challenge we need to consider in the physiotherapy process. And also, during this surgery, lymph nodes on both sides will also be removed. This increases the risk of fluid buildup, which can cause swelling. Because of this, we need to pay close attention to changes in size. We also need to teach the patient what to look for and how to take care of it. The internal urethral sphincter is smooth muscle structure localized to the bladder neck. Its primary function is to provide involuntary control of urinary continence by maintaining closure of the bladder outlet at rest. During radical prostatectomy, the bladder neck and surrounding tissue are surgically dissected, which may partially or completely compromise the internal sphincter. Damage to this structure reduces the passive involuntary mechanism of continence, placing greater demand on the external urethral sphincter and pelvic floor muscles. As a result, patients may experience postoperative urinary incontinence, particularly in the early recovery phase. Rehabilitation strategies, including pelvic floor muscle training, aim to strengthen the external sphincter and compensatory mechanisms to restore continence. During the radical prostatectomy, the anatomical proximity of the prostate to the urethral sphincter makes it highly susceptible to surgical impact. The external urethral sphincter, located just below the prostate apex, may be partially damaged or weakened during dissection or removal of the prostate. Even with nerve and sphincter sparing techniques, structural and functional compromise of these structures can occur. Physiotherapy and pelvic floor muscle training play a crucial role in rehabilitation by compensating for the weakened sphincter function and supporting continence recovery. After prostate surgery, the external urethral sphincter becomes the primary structure responsible for urinary continence. When patient came to me, it was October. He reports stress urinary incontinence during physical exertions, as well as loss of erectile function. At night, he wakes up 3 times to urinate. In his daily life, the patient is physically inactive, his body mass index is elevated, and he presents with abdominal obesity. An examination, the postoperative scar is firm and rigid. An ultrasound assessment of pelvic floor shows reduced muscle strength, only 2 of 5 on the grading scale. Patient is 58 years old. Because of limited physical activity and proactive behavior around the scar, the patient has developed scar tissue thickening and rigidity. The lack of mobility and avoidance of local stimulation likely contribute to the formation of adhesion and reduced tissue elasticity. To address scar tissue problems, several physiotherapy methods can be applied. First, soft tissue mobilization techniques, including gentle massage and mobilization, help improve tissue elasticity and circulation. Second, silicone patches or gels can be used. They are effective in reducing thickening, decreasing itching, and regulation of collagen synthesis. Also, if it is possible, we can think about physical procedures like ultrasound or shockwave therapy, but this is a little bit, we need time 3 months after surgery, and we need to consultation with a urologist about this question. Rectus abdominis diastase after prostate surgery is not a very common complication, but it may occur for several reasons. Like in my case, the surgery was performed through a larger abdominal incision. The patient already had a weak abdominal muscle or was overweight prior to surgery. And in ultrasound, we also see that rectus abdominis diastasis is in this case. Intra-abdominal pressure is a pressure inside the abdomen. It is created by the abdominal muscles, diaphragm, and pelvic floor working together. This pressure naturally changes during daily activities. Normally, when intra-abdominal pressure rises, the pelvic floor and sphincter muscles contract to compensate, which maintains urinary continence. In my clinical case, when intra-abdominal pressure rises, the pelvic floor fails to compensate, leading the urine leakage. To address this, the patient is performing target exercises to strengthen the anterior abdominal wall along with breathing exercises. A key focus is coordination, these movements with pelvic floor muscle activation. Transabdominal ultrasound is a non-invasive method used to evaluate pelvic floor function following prostate surgery. And also we can use transperineal ultrasound. It enables assessment of bladder filling and emptying dynamics, pelvic floor muscle contraction, and potential post-void residual urine. The examination provides objective data on muscle strength, coordination, and compensatory mechanisms, supporting both clinical decision-making and physiotherapy planning. In this particular case, pelvic floor muscle strength was assessed at 2 out of 5 on the grading scale. Avoiding diary is a simple yet viable tool for the assessment and measurement of urinary disorders. Patients are instructed to record the frequency and volume of urination, episodes of urgency, incontinence event, fluid intake, and nocturnal voids over several days. In my patients, I also say you can use this diary 2 to 3 days for the better results, and this I also give in the first consultation, and they send me 2 emails this back, and then we to change tray. In my clinical case, after completing bladder diary, the patient was surprised to see that they would actually hold longer volume without leaking. This encouraged them to try waiting longer between bathroom visits. The diary revealed frequent voidings of small amounts. The patients explained that they were doing this simply just in case to prevent accident. This helped establish a healthy fluid intake and regular voiding schedule. The International Prostate Symptom Score is an important tool for evaluating urinary symptoms in men with prostate condition. It allows us to measure the severity of symptoms such as frequency, urgency, weak stream, or nocturia in standardized way. Using this tool is not only help us understand the patient baseline condition, but also allows to monitor changes over time and assess the effectiveness of treatment or rehabilitation. In this way, this tool provides both patient and clinical with clear, measurable feedback about the progress of care. Physiotherapy can be initiated already before surgery, like rehabilitation, to teach breathing, circulation-promoting exercises, and correct pelvic floor activation. After radical prostatectomy, pelvic floor training is usually started as soon as the urinary catheter is removed. Commonly, it is 1 to 2 weeks post-operative, provided there are no complications and no wound is healing well. Currently, our doctors are also trying to remove the catheters earlier upon the patient discharge from the hospital. Approximately it is 3 to 5 days after surgery. This strategy also shows good results, which do not negatively affect to the patient's sexual functional status, and it allows for earlier gradual initiation of pelvic floor muscle training. Importance of proper breathing. Diaphragm and pelvic floor works in synergy. Correct breathing reduces unnecessary intra-abdominal pressure, prevents excessive load on bladder and urethral sphincter. Pelvic floor muscle awareness. Patient must first learn to identify and consciously activate pelvic floor muscles. Awareness ensures correct contractions and prevent compensatory by surrounding muscles. With this patient, we start our first 4 meets. When we meet consultations, we start with only pelvic floor with breathing, and after 4 sessions, we start with dynamic exercises, with loads, with high intensity trainings. When we show that when we see the patients have a good contracts of pelvic floor muscles and intra-abdominal pressure was under control. Optimization of pelvic floor contraction, the goal is not only voluntary control but also automatic activation. Training should include contraction during situation of increased intra-abdominal pressure, like coughing, sneezing, lifting, changing positions, physical exertions. Optimization helps restore continence in daily life without conscious effort. And this starting, like I say, in 5th session. A frequent error is performing exercise only in static positions. It's like lying or sitting. This does not successfully improve pelvic floor muscle functions during movements. Training must be integrated with movement and daily activities. Contractions should be practiced during standing, walking, lifting, sneezing, and physical exertions. Urinary incontinence is common immediately after surgery. The bladder and pelvic floor muscles need time to adapt. And this is also information which we need to tell our patient and explain. Many patients notice gradual improvement in urinary control within the first 3 months. Regular pelvic floor muscles exercise significantly support recovery. On this slide, we can see several types of medical devices that may help in cases of urinary incontinence. These include diapers, absorb pads, which are the most commonly used. There are also condom-time urine collectors, which can provide an alternative solution for some men. And also finally we see the penile clamps, which are sometimes applied to temporarily control leakage. All of these devices can play a role in managing symptoms, but our goal in rehabilitation is always to reduce the need for them whenever possible. In January, when patient come to me, he reports that they get up to use a toilet once a night. Also, assertionally, they can sleep through the entire night without waking. Mild urine leakage persists during high physical exertions such as intensive snowshoeing. When he goes out, they use urinary incontinence pads with lowest absorption level only for security purpose. Sexual rehabilitation should be considered as a part of recovery if it's relevant to the patient. Early initiation helps preserve erectile tissue health, improve blood flow, and support the return of sexual function. In cooperation with urologists, pharmacologic treatment may be prescribed to enhance penile blood circulation. Medication is often started shortly after catheter removal, depending on healing and absence of complications. Use of vacuum erection devices recommended as non-invasive method to promote penile blood flow and prevent tissue fibrosis. Frequency usually advised is daily or 3 to 4 times per week for 5 to 10 minutes, even if sexual activation is not attempted. Can be used together with pharmacological therapy for better outcome. And my patient uses vacuum erection device and also cover check injections. And they had a good result. In post-treatment outcomes, muscle strength, pelvic floor muscle strength improved from grade 2 to grade 3. And this is results. Sexual function is partly restored and the patient is satisfied with the result. Nighttime voidings, it's maybe he don't go sometimes, but waking at night was reduced to maximum of 1 time per night. The scar is no longer hard. It has become elastic and does not interface with daily activity. The patient no longer feels a tearing sensation. The patient successfully controls intra-abdominal pressure, but his body mass index is not improved. Active stability in pelvis has improved, and the patient can effectively coordinate muscle work during physical exertions. In March, the patient was informed that radiotherapy is scheduled to begin in June. In physiotherapy, we initiated education regarding potential complication of radiotherapy and the physiotherapy options available for their management. As the patient begins radiotherapy, we must anticipate several potential complications. Radiation can worsen urinary issues, leading to incontinence, strictures, or painful radiation cystitis. Patient may also face bowel urgency from proctitis and high risk of erectile dysfunction and severe radiation fatigue. Furthermore, previous lymph node removal increased the risk of pelvic fluid buildup, lymphocele, and painful swelling in the lower lymph like lymphedema. However, this is exactly where we pivot our approach. It responds to these 3 emerging challenges. We will set new physiotherapy goals and adapt our interventions. Our primary mission is to proactively adjust our treatment so the patient can successfully manage these symptoms and maintain the current functional status throughout the entire course of radiotherapy. Our rehabilitation approach before radiotherapy focuses on 4 key pillars to minimize side effects and improve treatment accuracy. It will be mindful breathing, deep breathing techniques, preserve pelvic floor elasticity, and maintain tissue mobility, preparing from irradiation. Fluid intake, instruction patients on regular water drinking pattern issues and stable bladder volume for every treatment session. Regular toilet visits, establish a strict, consistent voiding routine. Simple relaxation techniques reduce stress and, crucially, muscle tension in the pelvic area, making the treatment delivery smoother and more comfortable. By educating our patient on these 4 habits, we improve them to actively participate in success of their treatment. And thank you for being with me today. And this is a small greeting for Latvia Spring. And we will be waiting for questions. Thank you.
What would be the one advice, the take-home message for the participants who listen after your presentation? If you imagine that we have physiotherapists who are not specialized in a cancer care, so what would you say that every physio should know when they work with a cancer patient?
Get them to do physical activity. It's life-saving. They get back to function. Get them to exercise. There is no huge knowledge you need to know unless they've got very specific problems. You know exercise, you know how to dose, you know how to get them to participate. Get the patient to exercise.
I totally agree with Nirit. And we shouldn't be afraid. I think that the confidence it has to do with us, not with the patient. We have to be confident about what we are doing, not the patients. So this is the key message from me.
My message will be to share that we never be shy away from asking questions, even if it's come to intimate or sensitive topics. And if you think about pelvic floor, and also I keep it on vital side. The pelvic floor acts as a barometer for stress and anxiety. Let's make me sure we consider this in our daily practice. And if patient is anxiety or he's depressed, the pelvic floor also will be reflects on this. And this is a psychosocial support we need to do these patients. We are team. We are not only physiotherapists, and we need work with psychologists. We need with nutrition specialists work together. That we are team and we are not alone in this field.
Thank you, Marta. It brings together that exercises is medicine for cancer patients, and that we have to work together to make it happen. But then there is also a question about the precautions. What should we pay attention to when we work with patients diagnosed with cancer?
I think it goes to what has been said about confidence. Don't be afraid. I mean, they will not break in front of you. So you start low and you go slow, but keep advancing. Monitor the symptoms. Do not be afraid of getting them to be active. Just be attentive to what's going on, and it is part of our job to actually project confidence to the patients who are probably even less assured than us. So no special precautions. Just be attentive. You know how to deal with a patient.
We have to combine objective and subjective measures. We can monitor the subjective, the objective measures, but we also have to be attentive to look at the patient. We don't leave him alone. We are with him or with her all the time. So symptoms such as fatigue, for example, are a guide for intensity, not only the heart rate or the blood pressure. For example, the patient that I showed you, she very often has a very high blood pressure because of the chemotherapy. So in this case, I will not push her so much to give her 100% intensity. There is other day that I will work in a different intensity.
I also agree. Then I say in my clinical case, we will need to be ready to change our goal, to change our physiotherapy interventions we use, because the situation and how patient feel, if it is active treatment, can change to day to day. And maybe in this day we go with high intensity and next day it will be the low intensity. And maybe the active treatment will be changed, or maybe treatment was stopped, or patients goes in the palliative care. We need to be ready. If it's a chronic patient, this is maybe a little different how we work on this. But I also agree.
I think the patient will let us know how they feel and what they want to do today.
Yes.
The active participants, and they will let us know.
Thank you, Nirit. I was actually thinking that it was very nice to see in Nirit, in your presentation, that you had the patient had goals, and they were connected with the really basic everyday activities, and then we have to get them through the conversation from the patient, that what could be the goal for the rehabilitation. Then I have a few questions, Marta, to you regarding the sexual rehabilitation. And you mentioned in your presentation the pelvic floor exercises. Can you maybe specify which pelvic floor exercises the patient performed during the active movements? For example, I think maybe can you describe one of the exercises?
Okay. No,
Okay,
this first is
exercise
that we teach
example.
patient how to contract these muscles, and this is better when we see it in ultrasound or biofeedback, and we really know that patient do it correctly. And when we know the patients do it correctly, then we stand on one leg, standing on the balance pads or something, do like this. In more cases, we do jumps. We contract, we do pre-contraction before exercise, and then patients need to jump or need to make a fast movement or to roll to one side or get down and get up, and we watch what's happening. We use observation pads when we watch there is something leakage or no leakage. It's a better outcomes to see. And no, but the first we need to know the patients do it correct, and after that it's 2-3 times we need to train this, and then we can do active movements. It's also coughing, sneezing, and joking to try the intra-abdominal pressure to rise this and watch do the patients can hold the contraction without leaking.
And then there's one more specific question about the breathing exercises for the prostate cancer patients. What were you using in your clinical case?
It's more like diaphragm, but it's a deeper. We do this breath very deeply inside. It's also the first times I watching the ultrasound. If we see the movement in the pelvic floor, because when I do the breathing in, the pelvic floor is coming down, and when he inhale and exhale, when he exhales, the pelvic floor is go up. And this is very important to know, because sometimes we need to only relax these pelvic floor muscles. Sometimes if patients learn some information about Kegel exercises in resources, they do this incorrect with buttocks, with abdominal muscles, and with big intra-abdominal pressure inside, and the pelvic floor muscles is very tight. We need to strengthen them, but also we need to relax them. And this is also very difficult for patient, because I say you need to relax this muscle, but these muscles are weak. But in the beginning, we need to relax these muscles, and after then we start to strengthening in, and it's after also very important for these cases, that it's not always for strong, for more graduating scale to 4 or 5 we don't want. Sometimes we want to contract and do it correctly, and breathing it's very properly. We think about relaxation, it's also very useful to teach them. It's in the first sessions.
We have new graduate physiotherapists and physiotherapy students who are interested in the topic. So what would you advise And what would you say the students have to learn if they know that they want to work with patients diagnosed with a cancer?
You know, we're working on there will be a competence framework published by the working group on cancer. But basically, I think there's no big deal about it. It's basic physiotherapy. You need to know some things about different treatments and the side effects. You don't have to, go into the details of the chemistry or whatever. And I mean, I think for me, and I still remember my first two patients. It is very gratifying to work with these patients. I was a veteran by then, and the most grateful patients are because they are finally someone really helps them with what is important for them now that they are alive in their life, which is function and going back to life and whatever they like to do. So I think if you are a graduate in physiotherapy, and think go into oncology. You can go into other things as well. Go into oncology. It's not rocket science, and it is a very, very gratifying clinical practice. So it's simple. Just learn the base, some knowledge, medical knowledge, exercise, and then go for it.
So for me, it's very useful to see questions from students about what to learn as a physiotherapist who are willing to work in cancer, because it's basically what we are studying now as a working group. You will see our research work hopefully published somehow in the next future. But basically, we came out with a set of 13 competencies. I won't listen them all, but as Nirit said, it is important to start understanding what cancer is, the staging and grading system, the rehabilitation framework around the cancer, and then to understand how to apply the exercise principle to oncologist patients based on their different clinical outcomes, especially looking at their side symptoms after treatment. Then it's important to understand that we are there from prevention to end of life, or when the cancer journey ends in a positive way with survivors. It's important to understand that physiotherapists are there. It's also important to change yourself to be the more empathetic and supporting as you can, also in communication, also feeling what they feel. So the communication skill are very important. And this could sound not important at the beginning, but it is for us. It's to understand the network around you, because there are patients association, stakeholders around your territory, and you are the one who can put these people in network with all the realities around that could help them. So be multi-professional, not only in healthcare, but also outside healthcare field, to try to give them the best outcome they can. So you will read about our work, but this is basically, a summary of what we think it's important for us to know as a cancer physiotherapist.
I can just encourage everyone to understand that patient with a cancer diagnosis are patient. The patient has goals, and we know the techniques. We know the muscle strength exercises, we know breathing exercises, we know aerobic exercises. We just have to talk with the patient, as Nirit, Maria, and Marta already showed in the clinical cases.
I would like to tell to new colleagues a recommendation. If we don't exercise, if we as physiotherapists, because in Greece it's very common that we don't exercise, we have to be a role model for the patient. Okay, the patient is patient, but we have to give the good example. Okay, so first of all, fix yourself, and then you can be a role model for your patient. This is my recommendation, because I've seen students, that's why I'm telling that. And then you can do the seminars and the lymphedema, which is very important, and all the other things.
One more aspect we could look at is what can we do if we are from a low-cost country, if we don't have all the rehabilitation equipment. How can we enhance the patient care and outcomes?
We can work with the patient to find solutions which are doable for them. They don't have to come to physiotherapy. They don't have to go to a fancy gym. They need to do strength training. I mean, resistance training is a must, right? Aerobic is easy. You go riding a bike or running or walking fast. They must do resistance training. But the things at home, or they can, or public places or whatever. It doesn't. The question is a very good question, because there is a lot about social determinants of physical activity, right? We need, and it's important that we are aware of it. Help the patient find the solution that works for them, and that works for them best. It doesn't have to be a fantastic gym or whatever. We can find really. I mean, jumping squats don't require any equipment, and they are good resistance exercise. You don't need a lot.
Nirit says one important keyword, that is public places. As Europe region, we lead a you-founded project that the name is You Can Act, where basically we did cancer prevention treatment in public urban green spaces. If you go in literature and you check for PUGS, PUGS, you will find how much the public urban green spaces, the parks around your city, the open spaces around your city can impact positively on these patients. And if you put the green spaces plus a good physiotherapist who can motivate to exercise patients, this is incredibly amazing. Our people who participate in this project, they changed so much from doing nothing at home to give us a take-home message. Go outside, live your life outside, meet with people, exercise, don't spend time at home. So it was beautiful to see them so transforming themselves after the project. It was a 2.5 years project in Italy, Germany, and Ireland. It was beautiful. So basically, we did that without any tools, without any technologies, just physiotherapists, patients, and public urban green spaces.
And as we heard, they need encouragement, they need structure, and they need some follow-up, someone who can help to go through the process. There are some questions that we will not answer today. I remind everyone and encourage to look at the Europe region Cancer Working Group documents and the already recorded webinars. There are information recorded webinars from the World Physiotherapy Organization, the IPT-HOPE. They have very good information material about lymphedema management and the role of physiotherapy there, about prostate cancer as well. We have the info sheet, so the information is out there, and you can watch the recorded webinars before and get some more insight into this. And I invite everyone to come to the congress in November, because we will talk about the cancer and the role of physiotherapy. And yes, the call for abstracts, perfect. Also for new researchers. Also, this is the opportunity to meet already experienced colleagues, physiotherapists who work and are researchers in their daily life.
It was definitely so great to see so many of you here online. And I think now it's our time to wish you all very pleasant evening. Thank you for being with us.